Good morning. We have nothing to disclose. Laparoscopic sleeve gastrectomy has shown excellent results for the treatment of obesity. However, the effect of sleeve gastrectomy on gastroesophageal reflux disease is still a controversial topic. The aim of this study was to evaluate the influence of laparoscopic sleeve gastrectomy on reflux. Sleeve gastrectomy patients were studied before and at 18-month follow-up. Data analyzed were demographics, pre- and post-op GER symptoms, pre- and post-op endoscopic findings, morbidity and mortality. So this was a questionnaire that was used to assess symptoms in terms of frequency and intensity of heartburn and regurgitation. LA classification was used for esophagitis. If esophagitis was found during postoperative EGD, PPIs were prescribed for 12 weeks. EGD was repeated after that period of time only in patients with grade C or B esophagitis. Between June 2012 and July 2014, 285 patients underwent laparoscopic sleeve gastrectomy. Pre- and post-op data were available on 109 patients. 66% of them were women, age 40, initial BMI was 48. This slide shows the evolution of symptoms. In gray, we can see the status pre-op, and in red, the post-op. As you can see, symptoms rose from 33% to 44% after the operation, although this difference was not statistically significant. This slide shows the preoperative finding in symptomatic patients. As you can see, almost 40% had esophagitis and 45% had hiatal hernia. This means that 83% had some abnormalities on endoscopy. After the operation, we can see what happened with patients with preoperative symptoms. 41% of them reported the resolution of symptoms after the operation. However, patients who did not have symptoms preoperative, 37% of them reported de novo GER symptoms. So in these slides, we can see the post-op findings in symptomatic patients. 64% had erosive esophagitis and 23% hiatal hernia. This means that 88% of patients had some abnormalities on endoscopy after the operation. We found that there was a significant correlation between the presence of symptoms and erosive esophagitis on endoscopy. However, almost all the patients, 80% of them, reported mild symptoms, and they all had good response to PPI treatment. The most frequently reported symptom was heartburn, followed by regurgitation. Here we can see the evolution of esophagitis. Again, in gray, pre-op, and red, post-op, we can see the esophagitis rose from 20% to 34% after the operation, and this difference was statistically significant. Preoperatively, all the patients had grade A esophagitis. Half of them resolved after the operation, half of them remained the same. After the operation, patients who did not have esophagitis, of them, 29% showed de novo esophagitis. So here we have, after the operation, 34% of patients with esophagitis. Of them, the majority were grade A, 20% grade B. After PPI treatment, EGD was repeated. 70% of them resolved, but 30% remained the same. The same happened with grade C esophagitis, that none of them were able to resolve after PPI treatment. No Barrett's esophagus was seen. Here we can see the evolution of hiatal hernia. Preoperatively, 22% of patients had hiatal hernia, and after the operation, that number was increased to 35. Again, this difference was significantly statistical. So from the 22% of patients that were diagnosed preoperatively with hiatal hernia, only 25% underwent simultaneous repair at the time of the sleeve gastrectomy. But 50% of them showed recurrence of the hernia. After the operation, we could see that 16% showed de novo hiatal hernia. There were 4 patients that showed intra-abdominal bleeding. 1 of them required percutaneous drainage. There were no reoperations and no mortality. In summary, the prevalence of GER symptoms, esophagitis, and hiatal hernia was increased after the surgery. De novo GER symptoms was present in 37% of patients, esophagitis in 29%, and hiatal hernia in 16%. Symptoms were mild in the majority of patients. Severity of esophagitis was mild in the majority of cases as well. There was good correlation between manifestation of GER symptoms and presence of esophagitis. In conclusion, preliminary results of this study were enough reason for us to change our strategy. Based on preoperative evaluations, if the patient complains about moderate to severe symptoms or has esophagitis or a hiatal hernia greater than 2 centimeters, then the indication would be to perform a room-wide gastric bypass. Thank you.